Related. All righty. To the one person who just joined from the waiting room, welcome, welcome, welcome. To everybody else who is here, sorry for the glitchy intro. Just hit the record button now and excited that today is an RLR Friday VMR. Prof. Rez is on his way, will be joining us momentarily. But before we welcome him, I'd love to first thank the CP Solvers crew who are making this happen, starting with our one of our two newest Academy members. Nicola, you want to maybe tell people a little bit about yourself since they haven't met you as much as I would like?
Hello, my friends. My name is Nikola, and I'm a medical graduate from the tiny country of Croatia. But I spend most of my time in Austria, in Vienna, where I'm pursuing my PhD in the area of thrombosis and coagulation, specifically cancer-associated thrombosis. And currently, I'm on vacation. I'm on holidays back home, and I'm enjoying the weather. And I also really like to spend time with you guys all here, so that's why I'm here.
Nicola, I didn't share this with you then, but I'm in the exact opposite environment as you are. Both of us are on vacation, but I am in the desert. And since you were kind enough to show us your view, I'll show you mine. You will find no water out here. This is a place in Southern California, around an area called Joshua Tree. It has these very unique, really cool trees um, that are out here in the desert. So, really cool to see you. Thank you for joining on vacation. I too, like you, feel like this is a very relaxing and fun place to be. Um, so thank you for hopping on. Lyra, you're doing teaching points, huh?
Yeah, hi everyone. My name is Lyra. I'm a medical student from Russia, and it's very sunny here, and I'm not used to this type of weather.
Oh yeah. Is it warm too, or is it just bright sun?
Yeah, it's like summertime in April. For some
Yeah.
reason, we have like plus 20 Celsius.
Whoa. Oh my gosh, that's warmer than here. Wait, what time is it? How is the sun so bright this late?
It's 7 p.m. We
Oh,
have
okay.
something called white nights. It's basically a transition from spring to summer, where we
Yeah.
have really long sun days and really short
Ah.
nights.
That's incredible. Did you guys notice that as soon as you said spring to summer, Prof. Rez popped into view. It's unbelievable, like a flower blossoming. Good morning, Prof. Rez.
You said like a flower blossoming.
How are you?
I am well. I just woke up. I'm dealing with doing night
Yeah,
shift.
yeah,
My whole schedule is like all messed up.
yeah.
But very excited to be here. How's the desert?
The desert is amazing, Prof. Rez. It's our last day. Nikola is hanging out in the beautiful green and blue small town of Croatia, in Croatia, and I'm in the exact opposite. It's barren here, but I have an update for you, Prof. Rez. I have made friends with a rabbit, a jackrabbit, quails, coyotes, and unfortunately a rattlesnake too. And I'm gonna save the details on each of those stories for our evening hangout for RLR. So yet another reason, if all of you are on the fence about subscribing for RLR CP Solvers, I encourage you to do so because you will hear a lot more about rattlesnakes on RLR CP Solvers. But yeah, Prof,
I'm
that is
so
great.
intrigued.
Absolutely terrifying. But we have the exact opposite of terrifying, Prof. Rez. We have a second time case presenter. Unfortunately, we didn't have the privilege of having you last Friday. Charmaine and I were discussing, but we have our friend from South Africa, Zachariah, not to be confused with our other friend from South Africa, who is also named Zachariah. I will hand the mic to our case presenter today so you can introduce yourself or reintroduce yourself to folks who haven't met you, including Prof. Rez.
Hi everyone, my name is Zakaria and I'm a medical graduate from South Africa, currently doing my internship, what is known to you guys as foundational training, and I'm currently working at Tigerwell Hospital in Cape Town. And I'm excited to present yet another case. So I thank you all for the opportunity.
We're very, very excited for your case. If last time is anything to adjudicate by, we're in for a treat. So I will hand the mic to you, and hopefully we can hear Prof. Rez magic for the first alquad. Sound okay, Prof. Rez? Awesome. Alrighty, mic to you, my friend.
Okay. So I like my titles, and I've titled this case When the Clot Thickens. When the Clot Thickens. So the first aliquot, I'm called to review a 19-year-old female with new onset quadriparesis and confusion. She had been admitted a few days prior with a presumed diagnosis of pyelonephritis, but rapidly deteriorated, developing severe respiratory distress, requiring high care admission and BiPAP. And I'll leave it there.
Zachary, very nice to meet you, my friend. What a thrilling start to the case. Wow. And I'll just share my initial reflections because I think this case will have a lot more information. And when I look at this, I'm looking at the one-liner and I'm saying 19 years old. You know what that is, Robbie? That's Reza divided by 2 minus 1.
That is
Because
so
40 divided
impressive.
by 2, do the math.
Wow,
40
that is
divided
such
by 2
impressive.
is 20. 20 minus 1 is 19.
I can't believe you just woke up. That's very impressive, Prof. Rez.
So young. And that already tells you that you can like unleash your framework for when young people present to the emergency department. And that's either they had bad luck, they were in some kind of accident, but that's often quite obvious, or they have unlucky genetics and they inherited a disorder from, a parent, or they're involved in behavior that increases risk to the individual, whether it be drugs, sexual activity, etc. But be cautious. Those risky behavior should never be judged, and older people are allowed to perform them too. So you have to make note of that. So the age already caught my attention. And then you tell me quadriparesis. And that is shocking. Quadra means 4, paresis means weakness. 4 are two legs, 2 arms are weak. And so now my mind is trying to identify and localize the site of neuropathology. And immediately you can start thinking, is it the muscles? Is it the junction? Is it the nerves? Is it the spinal cord? And the symmetry may prioritize more the spinal cord than the peripheral nervous system, though it's not absolute. But then you tell us that, oh, she's also confused. And to add confusion to the problem that we're trying to define, all of a sudden it makes me go north of the spinal cord into the CNS. Now, that can either be to an actual site of pathology, or it could be due to something happening in the environment of the blood that's leading to all this devastation. Um, and with regard to actually, let me just pause there. I just wanted to share my initial reflections. Robbie, there's a little more to discuss there with BiPAP, Pilo. I'll just love to pass the mic to you because I'm still trying to understand the problem. And really, I'm prioritizing trying to localize the sites of neuropathology. And I'm using clues like the confusion to add weight to where I would put the lesion, though we can speculate in different ways on how this could still be a peripheral problem and not a central nervous system problem. But would love to pass the mic to you to layer on the rest of the information.
Yeah, Professor, I'm right there with you, and I think that the rest of the information is pretty plausible to say that a 19-year-old has been admitted for pyelonephritis. I think it's one of the very few diseases that can affect young women to this degree that requires admission. But I think we have to scrutinize the validity of that diagnosis and whether it represents a retroperitoneal pathology, and reminding us that the spinal cord is right next to the kidneys, and pain in one area may have been mistaken for pain in another. So it's a plausible diagnosis, but I think scrutinizing it is going to be very, very important. And the same with the severe respiratory distress. I think most of the time when people develop respiratory distress in the context of infection, we invoke the idea of ARDS. But I think in the context of a neurological syndrome evolving, we have to query whether it was the diaphragm that's causing this patient to decompensate, or more commonly that the patient is confused and aspirated. So, like you, I think I'm centering myself around what we're seeing now. The patient's paralyzed and confused, and understanding the severity of that is going to be key. And also invoking the idea that the two things you and I discussed separately, the neuro and then the pyelo and the respiratory distress, have been separated by days. It's not like the syndrome. I think paying attention to how these two things are bridged over what period of time, not seconds, not hours, but days, I think will also be another clue. All right, Zachariah, Mike to you. Very, very intrigued.
Amazing discussion. So the history of the presenting illness is that at baseline she'd been previously well, and then prior to her admission to the hospital, she had 1 day of right flank pain, no dysuria or urinary urgency, no nausea or vomiting. And that's on a background of 2 weeks of worsening dyspnea, orthopnea, bilateral lower limb edema, and PND. And at the time of presentation, denied any chest pain, fever, joint symptoms, constitutional symptoms, and the like. A past medical history: 8 weeks prior, she had given birth, and when she was discharged, she was given the provisional diagnosis of a peripartum cardiomyopathy. In terms of medications that she was on, she was at discharge on furosemide and iron supplementation. In terms of a social and family history, she's unemployed, married with one child, as mentioned recently, postpartum, sober habits, not currently sexual active, one partner, no known STIs, and no other relevant family history. In terms of allergies, she has none. In terms of the vitals, the temperature was 37.4, the heart rate was 120, the blood pressure was 110/68, the respiratory rate was 20 to 26, and the oxygen saturation was 98% on BiPAP with an FI of 40%. In terms of the examination, on the general exam, she appeared quite unwell. She had conjunctival pallor, no jaundice, no lymphadenopathy, no clubbing. In terms of the cardiovascular exam, she had bilateral pitting edema, an elevated JVP, a displaced apex beat, S1 and S2, and an S4 was present. She had a pericardial rub present, and no murmurs were auscultated. In terms of the respiratory exam, she had marked respiratory distress, which was evidenced by accessory muscle use and tachypnea, and she had bibasal crackles. In terms of the abdominal exam, the abdomen was non-distended, and there was prominent right flank tenderness, no hepatosplenomegaly, no masses. In terms of the neurological exam, it was quite difficult to perform because she was quite confused and was not able to fully cooperate. But the Glasgow Coma scale was 14 out of 15. She was disorientated to time, person, and place. In terms of the motor exam, the upper limbs, the power was 3 out of 4. There was increased tone in the upper limbs and brisk reflexes, increased reflexes. In terms of the lower limbs, the power was 3 out of 4 with decreased tone and increased reflexes in the lower limb. In terms of the cranial nerves 2 through to 12 were grossly intact. We were unable to ambulate the patient, and the rest of the neuro exam was quite difficult to perform as the patient was quite confused. And I'll leave it there.
Oh my gosh, Zachariah, I can't even imagine walking into this patient and seeing how sick she is. Just for clarification purposes, do you mind saying what the power was in the upper limbs? I missed that. I'm sorry.
The power was 3 out of 5
3 out of
in the
5.
upper and lower limbs.
So basically, the upper and lower limbs are symmetric in their findings. They both have increased tone, increased reflexes, and both are 3 out of 5 in power. Do you have a sense, I don't know if you plan to reveal this later, of whether there was weakness, a difference between proximal and distal, or whether there was 3 out of 5, both proximally and distally?
It was symmetric,
Symmetric.
proximally and distally.
I say all that, and I don't intend to talk about it because I'd love Prof. Rez to dissect this exam. I just wanted to influence my background thinking, and maybe I can take the additional HPI in the medical history, Prof. Rez. And I think, when we first heard that she had flank pain and she had no dysuria, I don't think that is actually enough license to doubt the diagnosis of pyelonephritis. Dysuria implies involvement of the bladder in the infectious process. And many patients have simultaneous cystitis and pyelonephritis, hence the dysuria. But about a third of patients do develop pyelo as a result of a pure ascending infection into the kidney without actual inflammation of the bladder itself. So that alone is not enough reason to scrutinize the pyelonephritis. But what happened thereafter is a significant reason to do so, was that the patient is developing flank pain not in an isolated context, and that context is that she also has elevated venous filling pressures. We later learn why, but before we do that, I think it's important to say, if you're getting flank pain in the context of a cardiac syndrome, you really have to worry about the possibility of the greatest mimicker of pyelonephritis, which is thromboembolism to the kidney parenchyma and renal infarction. So the truth is, we don't have to think about renal infarction in patients presenting with flank pain because the lack of systemic clues along with the presence of pyuria is significant enough to say we don't need to open that door. But here I think we need to open it because the heart seems to be diseased in the foreground, and we later learn why. Um, Peripartum cardiomyopathy is a fascinating cardiomyopathy that uh, had, uh, that occurs often in late pregnancy, but also can develop postpartum. It's a fascinating disease, often begins fairly abruptly and can be pretty severe. Most patients do have some gradual improvement after delivery, but the fact that she has ongoing heart failure isn't so much of a surprise. So I think what's happened here is that we have now more context, and that this patient was recently pregnant, has a heart that's not working well, and the context of the beginning of her syndrome, the pyelonephritis, occurred in too murky of waters for us to take the diagnosis of pyelonephritis at face value. And so it could very much be possible that she has pyelonephritis and a cardiac issue, but I think it also wouldn't be surprising to be able to lump in the flank pain to an asymmetric manifestation of heart disease. And I think the way that you'd be able to make progress is, of course, imaging. Pyelonephritis affects most of the kidney, if not all of it, versus an embolism is a focal disease process that is often wedge-shaped. Some subtle clues that you can accumulate on labs include an LDH and hematuria, which would be elevated in patients with infarction, in contrast with a normal LDH and pyuria, which would be present in pyelonephritis. So yeah, question pyelo, worry about the heart. But I'll pass the mic to Prof. Rez for the exam.
Can I ask you a question? Why didn't you say query Pilo? This is a question
Oh,
Pilo.
oh my gosh. That's for you, Prof. Rez. I'm not at that level yet, but let me try again. A query pyelonephritis.
That was just remarkable. Thank you for sharing all that wisdom, Robbie. Even though you got distracted in the middle of your discussion, I could see that you almost lost your train of thought. I was hoping you did, but you didn't. But let's get to the physical exam. And first of all, Zachariah, by the way, is Zachariah a common name in South Africa? Because you guys are the only two Zacharias I've met in my life. Is it or
It's uncommon.
it's uncommon? What's the origin of the name?
Arabic, but I think the uncle, biblically, the uncle of Mary was also Zachariah,
I understand.
John's
Thank
father.
you so much for
John's
that
father.
context. I can't delay it anymore. Let's get into the physical exam, which is quite shocking. And I would like to frame this physical exam as two main issues. One is the respiratory distress, and the other is the neurologic devastation. And then the question becomes, can we link these two together? Naturally, that's what our mind is going to try to do. With regard to the respiratory distress, we definitely have acute hypoxemic respiratory failure, and I would probably imagine we also have acute hypercapnic respiratory failure from the lack of taking breaths in. For the acute hypoxemic respiratory failure, it's easy to draw a linear line between the heart and the respiratory system. Zachariah has given us a phenomenal physical exam on the cardiovascular system. And before I talk about that, it's important to know when women become pregnant, the fetus is a foreign tissue. And naturally, the immune system is tempered a little bit, much less than the light, the sun shining on Robbie's beautiful phase, but the immune system is tempered a little bit so that you don't attack the foreign tissue. And then once you give birth, the immune system is revved up. So individuals with autoimmune diseases, it tends to be more quiescent or calm during pregnancy and then more active or flare once birth is given and the foreign tissue, being the fetus, is expunged from the woman. Now, what we have here is jugular venous distension, right? So elevated right-sided pressures. And S3, I'm sorry, an S4 confirming volume overload and a pericardial friction rub. The pericardial friction rub is when the two serosal layers, the viscera and the parietal, rub against each other, creating a sound. If you grab your hair and you just do this by your ear, you'll hear what a pericardial friction rub sounds like. It's very difficult to diagnose. And if someone is having a pericardial process with pericardial effusion, oftentimes they don't have a rub, despite having inflammation of the serosal surfaces. So what Zachariah has told us from this exam is, yeah, the patient's hypoxemic, probably related to the heart. And the heart is not just right-sided problems with the jugular venous distension, but likely left-sided. And there's a component of pericardial inflammation. Because what Robbie did in the previous aliquot was something is happening with the heart, and something is happening with the heart. You break down into the myocardium, the actual heart tissue, the endocardium, thinking of the valves, the pericardium, and the rhythm. Here, the rhythm is probably not abnormal, though we'll get an electrocardiogram, but we for sure have a problem with the pericardium. Now the question becomes, is the problem with the pericardium enough to explain what's happening with the left side, the right side, and the lungs? And you could potentially have a constricted pericarditis that could explain all of this. So a BNP is going to be very important because in that condition, the BNP tends not to rise because you don't have distension of the ventricles. So I think, and I would love Robbie's take on the heart too. I'm just going to leave it at that. I'll say, Robbie, I think there is pericardial inflammation. My next question is that enough to explain the rest of what's happening to the heart? Of course, we're going to get the troponin, we'll get the echocardiogram, but the heart may have multiple sites of pathology. But with the inflammation of the pericardium, I'm leaning away from pericardium cardiomyopathy, postpartum cardiomyopathy, because I don't view that as inflammation of the pericardium, though I may be mistaken. I don't have a robust illness script for it. Then we get to the neurologic devastation, which I'll talk about, but then I'm going to pass the mic to Robbie to both comment on the heart and see if there's any way you can link these two together, because I would honestly do that in real life. With regard to the neurologic devastation, we have someone who can't lift their arm and legs against gravity. And Zachariah was able to get probably the most important neurologic exam in this patient, which is reflexes. Of course, we're going to do a bladder scan to see if there's urinary retention. But brisk reflexes and increased tone or spasticity is an upper motor neuron finding. That's either the brain or the spinal cord. If you think about it, when you have spinal cord lesion, you may have hyporeflexia initially. That's acute hyporeflexia. But there's never a scenario where you have a peripheral nervous system problem, like the nerves that are involved in the reflex arc, that initially manifests as hyperreflexes or brisk reflexes. So assuming the reflexes were, authentic in the ability of the provider to obtain, all this is leaning towards something happening in the brain or the spinal cord. And so now I'm really nervous because it's one to just have a patient present with quadriparesis, hyperreflexia, and increased tone, but it's another to have them present like this with respiratory failure that's not just diaphragmatic weakness. There's definitely fluid in the lungs and there's definitely something happening in the heart. Again, I'm trying to identify the problem. I don't really have a differential diagnosis yet, but I would love to pass the mic to Robbie to see ways to link these together or any other thoughts he might have from this really rich aliquot of information.
Well, Fred, as always, there's nothing to add to your masterful dissection, and I'm right there with you. I think I'm having a hard time trying to figure out if the problem is pericardial or not pericardial, i.e., endocardial or myocardial, and I think that you cannot ignore a pericardial effusion given the implications for it. However, prevalence of prominent left-sided heart failure in pericardial disease is relatively underwhelming in general. And that's because the pericardial pressures impact the right atrium and right ventricle so much that usually there's the degree of pulmonary edema is minimal. And so I think the pulmonary findings are a decent argument against the oh my gosh, distracted again, sorry. A decent argument against the pericardium being the biggest driver, though it's definitely a contributor for sure. I also just realized that if we're invoking thromboembolic catastrophe, potentially to the brain, the spinal cord, or to the kidney, that a pericardial disease would not be implicated for that. You would require endocardial or myocardial disease in the form of endocarditis, or a really severe left ventricular thrombus in the context of a really reduced EF. So morbidity would have you fixate on the pericardial effusion until proven otherwise. But I think the two subtle clues that there may be an additional myocardial or endocardial component is the hypothesis of left-sided heart failure, which is a robust one based on the BiPAP requirements, and the hypothesis of embolic disease, which is again that's a much softer hypothesis based on flank pain in this context and neurological consequences in this context. Yeah, I'm very, very intrigued. I'm also really intrigued, Professor. I'd love to tap into your reflex. How are you right now dissecting the confusion part with the weakness part? Is your mind being cautious and separating them or putting them together? What is your mind doing?
Yeah, that's such a great question. And when I think about, quadriparesis and the exam that Zachariah presented, it's often in the context of a spinal cord lesion, like an actual physical, like traumatic event, unfortunately, that leads to those findings. And but here we have no trauma. So that frame, I think, is extremely powerful to say a traumatic quadriparesis with signal to the upper motor neurons. And with that sort of frame, I'm almost inclined to put more emphasis on something happening maybe at the spinal cord, but also north of the spinal cord, being the brain. So I'd be looking for structural lesions in the brain too, as opposed to someone who was in a car accident, who comes in like totally normal mental status and has clear indications that they have a spinal cord lesion. But like you said, I'm open to anything because this patient is quite sick right now. Can they have a hyponatremia? Can they have some kind of metabolic disturbance that's also leading to confusion? But I think this is what this does for me, Rob. It just makes me say, hey, I really want to get an MRI of this brain. Like I don't want to stop at like if I see a sodium as a 129, the BUN is 77. I still want to get an MRI of the brain because I'm already invoking potentially structural, non-traumatic pathology at the level of the cord.
So well said. Absolutely beautiful, Professor. Just to give you a little context, last week Zachariah presented his case of severe acute kidney injury with hematuria, creatinine of 15, hypertension, so on and so forth. What do you think the diagnosis was, just based on that information? Doesn't matter.
Um,
Wrong. It was TB.
I was
So
gonna say AKI.
yeah. So all I'm doing is warning you that Zachariah probably will have a very, very powerful twist.
Dude, can you imagine being attending on service and like asking a question of a learner and before they answer, be like, "You're wrong.
Yep.
You're gonna be wrong. It's TV."
Only
Shut
you.
shut your mouth, you learner. No,
All right, Zachariah, back to you, my friend.
Okay, so some early investigation, and I just want to make it clear from the start that this patient's TB workup was negative, so there's no surprises like last week. So I just want to share my screen quickly, just to share the CT that we got early on. So this is an axial view. It's a non-contrasted because we were concerned of possible bleed.
Robbie, do you want to take this? Are you working on CT heads or not CT heads?
Or whatever you want, Prof. Rez. I'm
Why
willing.
don't I try it? Because I don't really
Sure.
look at these often, and you can help correct me. Zachary, can you go from the beginning one more time? And then I can tell you
Sure,
to
sure.
thanks so. By the way, thank you for having the CT scan. You're incredible, man. So first of all, we're looking at the brain. That's the skull. That's the parenchyma. Stop right there for a second. Do you guys see how in that your lower left quadrant or the patient's right, there's like a little bit of atrophy there, Robbie? Like that looks like there's some tissue that's missing there. But let's continue. And again, you're seeing a little more of the sulci. Okay, stop right there. There looks to be a little bit of asymmetry, right? Like, doesn't it look like there's increased hypodensity on that right side a little bit compared to the left side? If we keep going, and once again, that right side, you're just seeing, look right there, right there. If you pause, look at that right side. Look at how much darkness there is compared to the left side. What does any of that mean? That's up to Robbie to determine. But a non-con CT is not the best for like acute infarction unless like tissue is dead and you're getting hypodense tissue presenting as sort of dark. But Robbie, why don't you comment and then Zachary can tell us what the formal read is?
Yeah, Prof. Rez, I completely agree. I'm so not used to seeing CTs of young people, and I think my first thought was, "Oh my gosh, does this person have cerebral edema?" But I reminded myself that this is not a 65-year-old. This is a 19-year-old. So I'll have to discard that hypothesis. But I agree with you. I think they're hypodensities. There's it looks like I forget what the term is. I'm not sure if it's hypodensity. Um, yeah, goes to show you how comfortable I am. But I agree with you. Where you are looking, I also saw uh, is my summary, and I wonder it looked a little bit more posterior predominant than it did anterior. So my reflex thought was, with very, very little robust knowledge, was um, that there might be changes um, in line with press. Possibly, but I think the more alarming findings are the fact that there are hypodensities and tissue loss. But my confidence is 40%.
And just to share, this is the one where the radiologist actually highlighted the abnormalities for us. And I'll share the report shortly at the bottom there. Let's go back, sorry. So there, at the bottom, the right-hand side, and in the center as well, again, there. Okay, so let me share the report. So this was a CT brain non-contrasted, and there were focal hypodensities in the right centrum, semi-ovale, and corona radiata, which suggested internal watershed infarcts. And there was a right posterior parietal hyperdensity, which suggested laminar necrosis. And unfortunately, a CTA or any contrasted study of the brain was unfortunately not done. In terms of hematology, white cell count was 11.7, and the diff showed predominantly neutrophils, 83%, hemoglobin of 9 with an MCV of 85. Platelets, the platelet count dropped from 56 on admission to 8 by day 3. In terms of the coagulation profile, INR, PTT, fibrinogen were all normal. D-dimer was 1.22, which was increased, and normal for our lab was less than 0.25. In terms of the inflammatory markers, the CRP was 60, the ESR was 29. In terms of urine studies, a urine PCR was performed, and it showed one gram over 24 hours. And we did have, I think our dipstick disappeared, but there was 2+ blood on the urine dipstick and 1+ protein. And in terms of a urine MCNS, it showed 50,000 erythrocytes, some muddy casts, and no growth. In terms of a renal function and chemistry, sodium, potassium, calcium, phosphate, liver enzymes, all normal. BUN of 33 and a creat of 5.65 milligrams per deciliter, and previously a baseline 8 weeks ago was normal. Other investigations, HIV was negative. Syphilis showed an RPR titer of 8 just positive. And previously the titer was 16. She was previously treated during pregnancy. In terms of an ECG, it showed sinus tachycardia. In terms of a chest X-ray, it showed cardiomegaly with severe pulmonary edema. In terms of an echocardiogram, which we got quite early, it showed severely reduced left ventricular ejection fraction, less than 20%, global hypokinesia, and tethered, abnormally appearing thickened mitral valve tips. And I'll stop there.
Robbie, I spoke a lot last time. Okay, so maybe what I'll do is just tackle some of the laboratory data, but that's, I think, one of the advantages of co-discussing is that you can tap into your colleague's mind as well, because there's a lot of abnormalities here, and we have to just interpret them in the context of the presentation. And we know that this patient has hypodensities in the brain on the CT scan. We also know that they're quadriparetic with hyperreflexes, and we know they're postpartum. So you're taking all of that data and you're trying to make sense of the labs to see if you can make progress in identifying a possible culprit that explains this unfortunate patient's presentation. So we have to take this very, systematically. Whenever you get a lot of labs that can be overwhelming, just take it one step at a time. Make it as simple as possible for your brain to solve. And of course, you're going to have colleagues to run the case by. You're going to have AI to run the case by to help you make even better progress. Right away, looking at the CBC, when you see this pattern, and what is this pattern? You should define this pattern. It's not pancytopenia, and it's not a single cell line that's down. You would define this as bicytopenia. But it's not enough to define it as bicytopenia because it's not the white cell count that's down. This is hemoglobin and platelet. And we know that she is in the peripartum period. So I don't know what to expect for these lab values to be, but I wouldn't expect the platelet to be 56. During pregnancy, there is increased volume and there is a drop in hemoglobin due to that volume. But seeing these two values, all of a sudden I have to ask the question, is something happening in the peripheral blood or is something happening at the level of the bone marrow? When one cell line is down, it usually is the peripheral blood. When three are down, it's usually the bone marrow. When two are down, it could be either or. But when it's hemoglobin and platelet, you better believe you have to prioritize the peripheral blood. And all of a sudden, one of the most devastating diagnoses in medicine come to mind, which is microangiopathic hemolytic anemia. So seeing that anemia and that thrombocytopenia, my reflex is to get an LDH and my reflex is to get a peripheral blood smear. Because if I can even identify one schistocyte in this context, the argument for a MAHA is extremely strengthened, extremely strengthened. And I love Robbie's mentors saying that when you do these smears, you're looking for schistocytes, blast. Do they have a history of heparin exposure and are there hour rods or not? I can't believe I remember that like you taught me yesterday, though you haven't spoken about it for a while. So then you get down to the D dimer, and the D dimer is up, and the D dimer being elevated tells you that there's some kind of microthrombi and the coagulation cascade is activated. So this, I think, actually adds additional support for the possibility of a microangiopathic hemolytic anemia. And this is where I start using some of the foreground data, and I'm going to pass the mic to you, Robbie, to interpret the rest of the data. Like if you tell me someone's having strokes and their D dimer is up and I'm worried about a MAHA, all of a sudden there's particular stuff that get prioritized, like TTP. TTP gets prioritized more than HUS, and TTP can come in so many forms. One that's triggered from HIV, lupus, one that is genetic and just someone all of a sudden has a TTP manifestation. That's so interesting. I wonder if in the peripartum period, if you are vulnerable to the genetic flavor, if it becomes more active. Just a thought that I will later look up if I'm not playing golf. Not sure if I'm committed to that or not, if it's worth the while, but Robbie will look up and and teach us later. Then DIC. Can this patient be in DIC? And remember, DIC is this really state of bleeding and clotting, and you can definitely get microthrombi and have, you know, ischemia to tissue. But this seems a little out of proportion, like this degree of hypodensities, and what we're assuming is infarction for DIC. And then there's other causes like antiphospholipid syndrome that can, and when you see platelets being this low, you have to consider it. And you have to make sure that she hasn't had exposure to heparin, though, even if she has, like these platelets are really, really low. So with that being said, with just this CBC in the foreground, I'm worried for some kind of peripheral destruction. I'm worried that that's leading to thrombi formation. I'm worried that that's leading to infarction, at least of the brain. But we'd love to pass the mic to you, Robbie, to layer in. And I'm really trying to purposely avoid the title of the case, which is so cleverly labeled. I actually, Zachary, believe it or not, Robbie and I published a case, The Plot Thickens. And that case was a patient with Waldenstrom's, macroglobulinemia, and hyperviscosity. Mike, to you, my friend.
Oh, Prof. Reza, that was such a elegant walkthrough from the thrombocytopenia to the to worrying about thrombosis. And yeah, I'm also in the space of saying, okay, I'm going to assume that the patient is clotting everywhere. And the most common reason why patients have clots everywhere is they have a central source control problem, and that they have a cardiac disease and there's clots flicking off everywhere. And I think that's a very reasonable hypothesis in most people. And the question is it a valid one in this person? And I think when you look at the echo, uh, you're like, oh yeah, there's something there. It's on the mitral valve. Is that the source of the patient's emboli? But Prof. Rez is a very compelling argument that this patient really has a very, very high concern for a thrombotic microangiopathy, because the thrombocytopenia alone doesn't explain why there's a small vegetation uh, on the cardiac echo. And so I think the question is, do we ignore that additional finding because it's a distractor from the hypothesis, or is it a subtle clue? And I think that's where attention to the words that are used by experts are so key, because MAHA stands for a micro angiopathic hemolytic anemia. And one way of emphasizing the micro is a radiologist should never be able to see the clot in a pure micro angiopathic hemolytic anemia. And so you could use the fact that you potentially see a clot in the heart as an argument against it, or you could try to use the fact that the patient seems to have both macro and micro thrombi. It's really hard to ignore the compelling argument that Prof. Rez says, and instead of using the echo as an counter argument, I think you use it as a filter and realize that there's really only two notorious causes for a simultaneous macro and micro thrombotic hemolytic anemia. And I think the most common is probably cancer. So really disseminated, often poorly differentiated solid tumors cause what's called merantic endocarditis, and they cause a MAHA and a TMA. They usually do so in the context of bone marrow invasion. So you'll often see leukoerythroblastosis as a powerful clue, and they have DIC. Could this patient have a metastatic cancer? Possible, but I think that the probability of metastatic cancer developing so soon after a patient has the stress test of pregnancy and successfully delivers seems a little bit less plausible, but I think important to be open to that possibility. The other cause is lupus, and Prof has already brought lupus up in its ability to trigger TTP, ability to trigger HUS, also ability to trigger antiphospholipid antibody syndrome, but also its robust association with Liebman-Sachs endocarditis. And so I think that I'd be really, really anxious to see what this patient's ANA is, and even more anxious to see it because we have a very interesting paradox. We're hearing that her RPR titer is persistently positive despite two things. One, she got treated during pregnancy, and two, she has low risk sexual behavior. And so I'd be really curious to see what her TPP is, her more specific treponemal antibody, because if her syphilis test is a false positive, that's yet another clue to the lupus plus minus antiphospholipid antibody hypothesis. And I guess the tough question for us, Prof. Rez, in real life is, do we anticoagulate this person at this juncture with a platelet count of 56? Or do we say, no, we don't have enough information? And I think that's probably the real life question facing us. I'm really curious what your take is. What do you think you would do in real life?
Dude, I love your frame of micro and macro and the intersection of what might explain. That's just so beautiful, man. The truth is, like, I'm not, because right now her platelet count is 3, which means she's at risk of spontaneous intracranial hemorrhage. So I think it's a very difficult question. And I think what might help the hematologist make that decision is the degree of immature platelet fraction. Because if you have a very high degree of immature platelet fraction, you're unlikely to bleed out because those platelets are very sticky and very effective in maintaining hemostasis. But it's yeah, and I so it's really hard, and I think we first have to confirm that we are dealing with clots, and even though the case is very strong for that, but yeah, this is a, honestly, I might say like let's if it ends up being lupus, let's just immunosuppress. And you'll see, I had a patient, Robbie, the young guy at Hopkins who ended up having multiple clots and APLS and lupus and had a high fever. And really, once we started immunosuppression, that patient had quite a bit of a turnaround. But we did also anticoagulate, but the platelets weren't low. Very tough question. I don't know the answer.
Maybe Zachariah has a little bit of insight of what you
You
all
just
did.
want me to keep saying I don't know the answer, huh?
Oh, no, I don't know the answer. I
I'm
have
just
no idea. I definitely wouldn't do it solo. But if this were me, I would probably take steroids, yeah, first before anything else. Yeah. All right, Zachariah, what you got?
Sure. So in terms of an additional workup, blood cultures were negative ×3, and some special serologies were sent, testing for Bartonella, Coxiella, Brucella, Coxsackie, Legionella, all negative. Troponins, persistently negative. In terms of a complement C3, the value was 0.32, and normal for our lab was 0.9 to 1.8, and C4 was 0.03, and normal for our lab was 0.10 to 0.40. And because of the abnormalities on the valves and the severe LV failure, the patient underwent further testing, and the patient underwent a cardiac MRI, and I'll play the video for you guys now. I will share the report as well. Okay, not sure if that showed much.
I just saw a still image, but I'm not sure if anybody else saw. Mostly at the liver, I think.
Ooh, sorry.
No problem.
I think it shared the wrong one.
That's okay.
Just...
Professor, the only success I can claim to have is to identifying where the heart is. But beyond that, I must yeah, I must admit my ignorance. What about you?
I'm right there with you. I think like we're predisposed to looking. I think there was like another hypodensity, if I'm not mistaken, on the valve. If you can go back, Zachariah, and oh, or never mind. Yeah, but I think I saw something on the valve. I mean, we're primed to think that based on the discussion. Yeah, if you hit play again, and then Stop right there. Oh, it'll come again. I remember I saw it again. But honestly, this is yeah, right there. You see, there seems to be like darkness there in the heart that's separated by a rim of white. So I wonder if that's a mass or something. But I never look at cardiac MRI, so it's just a hypothesis.
Mm. So radiology interpretation of the MRI was that there was a small pericardial effusion, and in terms of the valves, all valves appear normal and competent, and in terms of the major coronary arteries, all appear normal, and the final report suggested non-necrotic myocarditis with severe LV dysfunction. I'll also note earlier that while rushing the patient for imaging, I noticed a rash that I had initially missed on first pass examination, and I'll share the rash now, and I'll end the aliquot with the rash.
You're on, Robbie.
Oh my gosh, so sorry. I keep moving because it's so windy. Prof. Rez, this is the best, most amazing challenge. So in order to see this rash, I'm gonna have to walk over here, but I'm gonna do it, Prof. Rez, because I'm on. No worries. Okay, so I think I see that this is at the level of the ankle, and I'm trying to figure out the color of it. Um, it's on the spectrum. I'm inclined to think purpuric, not because of the color of the rash, but because of the distribution. We know this patient's platelet count is 3. Um, so I just see these pinpoint macules that especially on the foot seem to be in a reticular location. I can't quite tell for sure. Um, yeah, my confidence level is low, but I'd be wondering about either ischemia, which would be supported by the reticular appearance, or just the fact that this is petechiae in the context of bleeding. And I'm inclined, even though the platelet count is 3, just the distribution at the bottom of the foot is very lacy appearing. So would be thinking about that. What do you think, Prof. Rez?
I'm right there with you, and boy, we're just taking back to Emory, aren't we? It seems like it's a never-ending theme. Back to that CPS. But yeah, no, I have nothing to add. I'd love to hear from Zachariah as yeah, what you guys thought and what happens next.
Okay, so the hemolytic screen retics were up 6.5%. LDH was elevated at 706. Haptoglobin was low. Ferritin was normal, and the direct Coombs was positive. In terms of the peripheral smear, I did want to share the smear with everyone. I just wonder if I'm sharing too many things
No,
now.
not at all. Like honestly, this is incredible.
So this was the peripheral smear.
Yeah, and I think what you see here is helmet cells. Like you see red cells that are fragmented. So to me, these are schistocytes, and I think we've confirmed microangiopathic hemolytic anemia.
So in terms of the smear, it showed a true thrombocytopenia with no clumping, and it did show schistocytes. In terms of an autoimmune workup, rheumatoid factor was normal, anti-GBM normal, ANCA, ANA, anti-double-stranded DNA, all negative. In terms of ADAM-TS13, the activity was more than 50%, which was normal, and I'll leave it at that.
I will say this. I just opened up the chat because a statement really grabbed my attention. One schistocyte in the right context is enough. I love that, Lucas. And Robbie, we can officially say we're 1 for 5 on images.
Your math is crushing today, Prof. Rez. Wow, age, percentages.
So, dude, where are you thinking? Like, honestly, I would love to tap into that beautiful mind of your blood schema. Like, where are you with all this?
Oh, Prof. Rez, I think that you laid it out so well. Like it's really now that you've proven this is a thrombotic microangiopathy, I think the question is why, and I think we all have a list of things the way we think it through. And just to be systematic, I think the fact that the Adams CS13 is activity is greater than 10% effectively excludes TTP. The fact that the ANA is negative effectively excludes lupus and scleroderma. And so, quite frankly, we're probably left with two things. Does this patient have cancer? And cancer doing so, that seems a little bit less likely based on things that we discussed. So I would probably be most worried about the patient having primary, not secondary, antiphospholipid antibody syndrome or APLS, based on based on two things. I think the RPR positivity suggesting anticardiolipin antibody presence. But also, I think if you apply it and ask yourself, what TMA or thrombotic microangiopathy has a propensity to affect the skin? And by far and away, the most common cause of a thrombotic microangiopathy to affect the skin is antiphospholipid antibody syndrome. And I learned this from our dear friend Andrew, who presented a case. I forget what context it happened, but that poor patient thrombosed everything, including their nose, ears, on their skin. So I think the no misdiagnosis here is catastrophic APLS, especially since everything else is negative. So that's where I'm at. But catch me up to speed. Where is your brain going?
Well, I'm right there with you. Thanks. I mean, that's so incredible to like put that the skin clues and everything. I'm right there with you. And I'll just add that like again, during the pregnancy, the immune system is calm. You like now the story can all be sort of linked together that you deliver the baby, the immune system becomes more active, and propensities to autoimmune diseases flare up postpartum.
Amazing. So in terms of further workup, the patient's skin was biopsied, and the biopsy showed mild chronic perivascular inflammation and no evidence of obvious vasculitis. And in terms of a renal biopsy, it showed some glomerular necrosis and evidence of glomerular ischemia. It also showed chronic interstitial inflammation and focal tubular necrosis with luminal red blood cells and prominent cellular proliferation in the vascular. IgA, IgG, IgM, C3 staining on immunofluorescence were all negative, and IgM was weakly positive, 1 plus. And the pathologist's comments was findings in keeping with subacute to chronic thrombotic microangiopathy. And in terms of the final workup that we did, the anticardiolipin IgG was positive, anti-beta 2 glycoprotein and lupus anticoagulant were all strongly positive. And the final diagnosis was catastrophic antiphospholipid syndrome.
Robert, I'll just jump into really thanks, Zachariah, for such an outstanding case because last week, Prof. Reza presented a very surprising case of a TMA, a thrombotic microangiopathy, without a MAHA. And today, I think, taking us through a very, very similar journey with different features. Your case presentation was absolutely outstanding. I'm just really intrigued, Prof. Rez, about how this is without lupus because of the low complements, the patient's age. I'm just very, very intrigued. And the thing I'm really curious about is, do patients who might eventually get lupus first show up like this? And that's a curiosity that I have. I'm curious what your take is on that in this case, and then I'd love to hear what Zachariah has to say.
Yeah, I also want to thank Zachariah for presenting this in the way that he did, and Robbie for co-discussing, and Lara for her teaching points. They look really nice. Dude, Robbie, that patient, remember at Hopkins, he first had TTP like years prior and then presented with lupus. So I don't know, just based on that one case, to me, it could be like APLS and then lupus.
That's so cool. I didn't realize that about that patient, Prof. Rez. That's very, very illuminating.
You remember because Alan Gelber labeled that one past his
Yeah,
prologue.
I remember now. I remember. Oh my gosh, I had forgotten, but I completely remember now. Zachariah, how are you putting this together? What a journey you went on. Oh my gosh.
Yeah, so it was a fantastic case and very high stakes case because the patient was quite sick and we were under pressure to make a diagnosis as soon as possible. So in terms of the final diagnosis, the patient was diagnosed with primary antiphospholipid syndrome and triple positive disease. And the clinical features thereof was the skin, the manifestation, livedo reticularis, the rash, non-infective endocarditis, and then severe myocardial dysfunction that EF of less than 20%, and it was presumed to be due to microvascular disease. And unfortunately, no CAT was done because of the acute kidney injury. And then CNS manifestations in the form of the watershed infarct, which were likely due to thromboembolic, and the acute kidney injury with thrombotic microangiopathy. There were also some features of the case that were not fully in keeping with catastrophic antiphospholipid syndrome, and those were the hemolytic anemia, the very low thrombocytopenia, and the unexplained or low C3 and C4, which was low on initial labs and then resolved. So yeah, the patient was diagnosed with triple positive primary antiphospholipid syndrome. And some teaching points regarding the disease is that it's quite rare, and it's a rare and very severe form of antiphospholipid syndrome. And then there's essentially widespread microvascular thrombosis, which affects multiple organs simultaneously. And it's often triggered by an inflammatory insult that could be infection, surgery, or pregnancy. In this case, on further history and further review of the patient's medical records, the final, or the end of the pregnancy was quite complicated. It was complicated by preeclampsia and HELLP syndrome. And that's the time the patient was labeled, given the diagnosis of peripartum cardiomyopathy. And also then an interesting point that Zakaria and I learned together was that how did catastrophic antiphospholipid syndrome cause the myocarditis? And there's many hypotheses and speculation, but basically it causes microvascular ischemia without large vessel occlusion. And the heart is often affected by diffuse microthrombi in the small coronaries, and this doesn't necessarily lead to the classical infarction, which would cause myocyte necrosis and raise the troponins. Rather, it would cause patchy ischemia, interstitial edema, and myocyte dysfunction, but not necessarily death. And the CAPS-related myocarditis with negative drops may be explained by the above, as well as complement-mediated endothelial damage, or transient or low-grade myocardial injury below the detection threshold. So I just want to thank you guys for the case, and I'm looking forward to presenting my next case in June, and I promise it won't be another TMA.
I don't know what to say, Zakaria. You treated us to two back-to-back really, really rich educational sessions on Friday. I don't know who's presenting next Friday, but they have a tall order for sure. Thank you. It's been a pleasure to get to know you a little bit better here today, and excited already for what you have in store for us. All right, Lyra, mic to you, my friend.
Yes, thank you both Zacharias for such amazing case. Without Zachariah, there would be no session today. It was really incredible journey, which started with a very young patient, which was 19-year-old female that presented with new-onset quadriparesis and confusion. And first, we need to really understand the patient, and the young page stood out, which basically means that either patient has bad luck to develop disease, or she has bad genes and has some inherited disorders, or she has some risky behavior that could predispose her to development of this disorder. And also she had a known diagnosis of pyelonephritis, and we learned that we need to take the known diagnosis with a grain of salt, and pyelonephritis could be a mimicry of retroperitoneal pathology, and also referred pain from, for example, spinal cord. And we also need to consider its connection to chief complaint, which in this case was quadriparesis. And on further examination, we found that the patient didn't have any dysuria, but the absence of dysuria doesn't mean no pyelonephritis, because dysuria is lower urinary tract symptom, and pyelonephritis is the higher portion of the urinary tract. But the presence of lung pain at the setting of heart failure put this diagnosis under the question mark due to possibility of systemic embolism. And for that to rule out, we needed imaging, LDH, and urinalysis. Then we entertained the chief concern, which was quadriparesis in this case. And when we faced with the neurological concern, we really need to know the localization of the problem. And since we knew that this patient had symmetric quadriparesis, it localized us to the central nervous system rather than peripheral nervous system, which was further reinforced by the presence of hyperreflexia and increased reflex tone in this patient. And if we add the confusion to this equation, we place ourselves to the brain rather than spinal cord. And then we entertain the possibility of the heart problem in this patient. And for that, we have an anatomic approach. Either this is a functional, which means a rhythm problem, or structural one, which can be placed either in the endocardium, myocardium, or pericardium. And since this patient had a pericardial rub, we translated that into the pericardial inflammatory pathology. But the next question was, what is this enough to explain both left heart and right heart failure? Probably not, but it's still possible with the diagnosis of constrictive pericarditis, which we can rule out or rule in with the single test, which is BNP, which will be normal in the setting of constrictive pericarditis because there is no right atrial distension and therefore no necessity to secrete BNP. And our additional considerations were myocardial problem with low heart failure, with low ejection fraction. And given this patient's history, which was a recent pregnancy, we considered the etiology to be peripartum cardiomyopathy. And the second consideration was endocardial problem due to presence of systemic embolism. And the real pivotal point in this case was the CBC, which showed bicytopenia. And if we're facing some cytopenias, if we're facing the three line, all three lines are down, which basically means pancytopenia, we usually find ourselves in the bone marrow problem spectrum. If only one line is down, it usually means that the problem is on the periphery. But with two lines down, it can be really anything, both the periphery and this bone marrow problem. But if those lines affected are the platelets and the hemoglobin, we really need to worry about peripheral problem and TMA in general, which was further enforced by the presence of elevated D-dimer in this patient. And we also entertained the possibility of possible vegetation on the echo of this patient. And for that, we thought that MAHA should mean microangiopathic anemia, which means that radiologists should never see the clot on the imaging. And this can happen if we, for example, have a combination of micro plus macroangiopathic hemolytic anemia, for which most common cause is cancer. And also lupus can do that, which we were thinking about with evidence of positive RPR, which could be false positive. And the next step to the final diagnosis was that we confirmed the diagnosis of TMA with peripheral blood smear, but we also noticed the rash on this patient, and the TMAs that really like to affect the skin is really a diagnosis of antiphospholipid syndrome, which was a final diagnosis in this case. And the quote for this session is that one cystocide is in the right context is enough to diagnose TMA. And that's it from my side.
Wow, that was incredible, Lyra. Wow. It's almost like when I write my notes now, I have AI in the VA and I just put in random thoughts and I say polish this and it puts an output of a very polished note. And I feel like that's what Lyra just did for us, Robbie. We were all over the place, but you really organized it superbly. Thank you for that. Thank you, Nicola, for scribing. It was so easy to follow this case along. Zachariah for presenting the case, and Robbie's parents for making Cam. 36 years ago, coming on April 21st is Robbie's birthday. April 21st. He's gonna turn 36. Doo-doo-doo.